We're now open for questions. If while waiting for everybody, I'll ask one of the first ones. So something that was touched on by a couple of the talks, but I think is really important to note, is the fact that what makes this different from a lot of other parts of medicine is that both, not just for individual physicians, but institutions can opt out. To what extent is this in practice an actual burden based on the data that folks have collected?
Not doing very good. Okay. Maybe I can speak a little bit to that, David, from the Oregon experience. Part of the issue with developing the patient navigator programs by Kaiser and a couple other institutions was because institutions, hospitals in particular, are allowed to opt out. Any healthcare institution can opt out according to the law. In fact, it's not really an opt-out clause. It's really no legal duty to participate, which is different than a conscientious exemption opt-out. That said, with that as part of the legal and institutional landscape, many patients do find hurdles, difficulties. Patients, in my understanding, are not engaging in doctor shopping. It's very often a circumstance in which they find it very difficult to go from a physician that says no to a physician that is willing to actually participate. So the navigators, or what Helene referred to as the matchmakers, kind of this insider lingo that's been appropriated here, suggests there's a lot more difficulties because of opt-out clauses for both individual physicians, pharmacists, hospice programs, and hospitals.
And can I say, just briefly from the Netherlands, I thought it served a positive, actually, when physicians and I wouldn't see entire institutions opting out, but individual providers would choose to. And I saw that actually encouraging more dialogue. It meant that what people would do is they would go and they would talk to their general practitioners before any illness about what their stance was on euthanasia. And so it actually encouraged dialogue, and dialogue encouraged more processing, which I thought was positive.
I don't have an answer to the question, but I want to question its premise, which is that it's unique, right? I think there's conscience clauses, obviously, all the way back since we legalized abortion after Roe. There's conscience-based objections to that. There's state-level conscience-based objection rights across the board.
Yeah, but there's arguably a duty to refer in a lot of those cases, and where there isn't here.
Okay, so that's the particularly distinctive aspect that.
Yeah,
okay.
The institutional opt-out, not just. We have some questions.
Sure, I'd just like to direct my question toward Professor Norwood, whose description of the Dutch experience was interesting, and I wondered whether you think there's any basis for our thinking that there's a necessary connection between a request for assisted suicide or euthanasia and having family meetings, doctor visits, the possibilities for reconciliation that you were talking about, and if there isn't, what part of the Dutch experience is better for us to emulate in the United States and more important?
Yeah, so I think, because I didn't get to the point about what I think might be happening here a little bit, and I think that's really for my colleagues who do the research here to talk about a little bit. But what my understanding from reading a little bit of the literature in the U.S. is that the dialogue is probably happening. Now, it's probably not happening in the same way, and certainly the involvement of the general practitioner in the lives of these families is not likely to be quite like it is in the Netherlands, where they have a long tradition of doing family medicine and treating multiple members of the same family over extended periods of time. So I just think that what I'd love to question my U.S. researchers on is, are you seeing the dialogue? Is it lasting for the length of time that some of the dialogues are lasting in the Netherlands? And it might be different in the places where in Oregon and Washington that have had a little more time for the law to come to a steady. So, I think there's a lot of potential questions that I'd want to ask my neighbors who.
Yeah. I'm not sure you got the full thrust of it, so maybe I'll ask it more bluntly.
Okay, go ahead.
Why should it be that you only get discussions with, with the family and the possibilities for reconciliation if you ask for euthanasia? Why shouldn't everybody get the possibility for those kinds of discussions?
Yeah, I think for the Dutch, I'll tell you what I saw with the Dutch. The Dutch general practitioners get very involved in the family, and they do not feel until it gets to be a life and death situation and they get called in to do the euthanasia, until they get called in to do that, that is their only way that they feel activated, because they still have an obligation. This one person Dr. Jansa, who I was describing, she wasn't allowed to go share information about her mother with the daughter, but she did feel able to go and say, hey, you should talk to your mother and try to encourage a family discussion. But she couldn't go beyond the ethics of her profession and share information with another family member. So that's just not going to happen. But there was something special that seemed to happen when a euthanasia request was initiated, and it gave, I think, the physicians a little more power to initiate the discussions, and discussion is just very, very rooted in Dutch ways of connecting. So they do a lot of coordinating and discussing. So that's how they played it out.
Hi, I'm Liz Stokes, American Nurses Association. Dr. Pope, I believe you alluded to this in your presentation about access, or maybe lack of access for some patients. And I wanted to just get your thoughts about the role or the potential role of telehealth for patients that are in rural or remote areas to avail themselves of this practice.
Yeah, that's a good question. So what I did suggest is we should consider expanding to NPs. That's a way in which we're currently dealing with shortages in rural areas in primary care. Is we're expanding scope of practice to fill in the gaps. And you're absolutely right. The telehealth is another way to fill in access gaps, especially in rural areas. I'm not aware of any literature talking about the intersection of telehealth and medical aid in dying. So
there actually was an article last year. It was in the Journal for Nurse Practitioners, which is why I brought this up. And that's what they're talking about, is trying, because in Canada, nurse practitioners are able to prescribe and administer. Right. And they're trying to figure out how to reach patients in remote areas, and they're doing it via telehealth. Yeah, no,
so that would be yet another great, for the PhD students who are watching this today, great topics for theses and dissertations and other study. Absolutely agree, it should be explored.
Okay. Thank you.
Hi, I'm Kim Callanan with Compassion and Choices, and I just wanted to clarify one point, and then I had a question for Thad. So on the first point, I just wanted to be sure that people had the accurate information about support for this law. If you look at Colorado as an example, that ballot initiative was won with 2/3 support across every demographic group, and it was actually the most yes votes that any ballot initiative in all of Colorado's history has ever gotten. And you can look at polling data after polling data, and you'll see there's strong support across every single demographic group. So I did want to correct that point. To my question for Thad, one of the things that you really pointed to is a challenge that you have around access, and the fact that there's a lot of requirements in place. And I know we hear frequently from people who are trying to get through the law that what they face is an inability to get through the law. So I was curious if you could talk a little bit about how the law protects somebody with a disability, and what those safeguards are that are in place.
Yeah, so I mean, again, just to reiterate one thing that I said at the very beginning, which is I wasn't advocating anything, right? I was just presenting that other jurisdictions are doing it differently, and they have wider eligibility. And so far, there isn't evidence that that has resulted in really, really bad things. Now, of course, Victoria hasn't even started yet, and Canada doesn't have a really big track record. I also, the second thing I want to do is reiterate something David Ortlicker said, which is you have to look at the status quo, right? If there's a risk that disabled individuals are going to be pressured into ending their lives prematurely, that risk exists today, and it exists in the 51 jurisdictions in the United States that do not have medical aid in dying. So, and I know, I mean, there's people who have written about being pressured to, stop dialysis or stop mechanical ventilation and so forth. So that risk exists today, and we absolutely should understand how to mitigate the risks of undue coercion and pressure. So I don't know that risk is any greater when it comes to medical aid in dying than it is with respect to the status quo. And then finally, I'm not aware, and I don't know that it exists, that there is actual data or evidence that there has been undue coercion or duress in Oregon, Washington, California, Colorado, Washington. So it is, the risks exist. I mean, the one thing I guess, I know I'm talking too long, but just to cap it off, absolutely there's a risk of error. Absolutely there's a risk that somebody's going to get this prescription who should not have gotten it. Absolutely. But the question is, and we should mitigate that to the absolute fullest extent possible, but you can't possibly pretend that there isn't that risk.
I would also like to respond to that question. The Pew Forum did a in-depth polling in 2013, which found the ethnic breakdown of views on assisted suicide, and African Americans came in opposed 65% to 29%, and Latinos came in at about 2 to 1.
Yeah, and I will
Excuse me, let me finish, please. And in Massachusetts, where we have precinct by precinct results, the places that voted overwhelmingly in favor were areas that are heavily white and professional, like Amherst, which went 80% in favor, but in the leading Latino towns like Holyoke, Chelsea, Lawrence, and Springfield, the margins against were up towards 2 to 1. Also working class white areas. People who are not treated by medicine with the same level of respect that people in this room are used to are much more suspicious of doctors having the right to make you dead. There was one precinct in Mattapan where 99% of the people voted for Barack Obama and 72% voted against assisted suicide.
Thank you. So I'll just add that since 2013 was now, 4 years ago, we've seen a really different trajectory for this issue. So the Colorado data, I think, is much more reflective of all the national data that's out there now, and there's a ton of it. The Gallup poll data has breakdown by ethnicity group. And then if you look at what the trends that are happening with national organizations like the National Alliance, the National Hispanic Health Alliance, those organizations have switched and dropped their opposition and moved to neutrality.
Yeah, not to belabor the point, but some of these polls ask, shall a doctor be able to prescribe drugs to someone who's in pain, excruciating pain, et cetera? So there's a lot of muddying of the waters here.
Anita Silvers wanted to make a comment. Anita?
Yes, I just wanted to ask whether there are any data or perhaps a study is needed about whether or not physicians are especially careful and try to discourage individuals with disabilities from using this procedure that is available without such objection or extra barriers for people who are terminally ill but do not have long-standing disabilities. So I think there are two sides to this.
Yeah, that's a very interesting question. What data do we have right now, and what data do we think we need?
I can speak to the Dutch experience a little bit. So what the providers would do is if anybody came who was sort of outside of the realm of the typical case that they were comfortable with, and this would be somebody who maybe the family they didn't have family support, because for the Dutch that was very important. So if they didn't have family to help have the conversations, they would stall the euthanasia request. If somebody came to them with mental health issues or depression, they would stall the euthanasia request. If somebody came to them who was maybe outside of the culture and didn't know the culturally specific ways to ask for the request, I had a Suriname older gentleman come in and beg his doctor to kill him, and she did not take that request seriously, and she talked about depression and what he, why he would want to express a willingness to kill himself. So all those resulted in the Dutch stalling, which was a technique that worked for them.
I know that there's data showing that in Oregon there's a lot of cases where physicians used legal bases for saying that people failed to meet the legal requirements, and there's been certainly concern that that sometimes been utilized as a way of avoiding access in cases where people don't want to provide it in different ways without formally opting out in some way. But I do wonder, this particular question, though, I think is a good point to raise, Anita, about the extent to which we really understand or know what happens in practice for folks who are sort of have long-term disabilities in addition to having a terminal prognosis. So,
we don't really have knowledge on what happens inside the doctor's office, but we did get one letter from Catherine Judson. She wrote to Hawaii saying that she brought her husband in to see the doctor to get some much needed relief, and she could overhear the doctor making a sales pitch to her husband for assisted suicide using the kicker of, you have to think about your wife. Once doctors are in the position of prescribing assisted suicide, which is seen as a benefit, they will be in the position of advocating for it from their vastly unequal position of power.
I guess I've had the opposite experience, that it's sometimes very, very hard to get doctors to use their power, which they'll use for other people, but they're very concerned about people with disabilities because they think that they are exposing themselves to exactly that kind of criticism.
One way, I think, to mitigate the variability in what exactly physician to physician is discussing with the patients is to use a certified patient decision aid, so then you at least know that all patients who are asking for this medication got the same uniform, balanced presentation of risks, benefits, and alternatives.
That would be good.
Yeah, well, just one quick thing, just because it's been brought up so much. The Disability Rights Oregon, this is an organization, and I have here a letter from the executive director of Disability Rights Oregon, that DRO has still not received a complaint of exploitation, coercion, or an individual with disabilities in the use of Oregon's Death with Dignity Act. This was dated February 16, 2016. So that covered everything from the implementation of the law in 1997 through 2016. And that has been, by and large, my experience whenever I've traveled to now a dozen different state houses where individuals suffering from long-term disabilities in wheelchairs and the like will approach me to say that they also want this option if they were to find themselves to qualify, being that they were found to be terminally ill with 6 months or less to live, like Brittany. So the statement from the Disability Rights Oregon, as well as just the firsthand conversations that I've had, shows that this has been put into practice very carefully. And there still has not, according to the executive director of that program, been a single case of that sort of abuse or coercion. So just figured I'd share that.
Everyone who is terminally ill, who is disabled, and one organization's experience does not reflect the total.
I'll let you, since you've been sending so patiently in line, I'll let you take the last question.
Mr. Kelly, you used two examples of why there are problems with the law that I want to take a little bit of issue with. One was that there are some patients who live longer than 6 months. The other was your example of a woman who was misdiagnosed. And I look at this the opposite way. If the law also says nobody's coerced into taking the medication, so if some people are not near the end of their life to the point where they're so miserable they want to take the medication, they live longer. So to me, that's a good thing about the law. And the same with the woman who was misdiagnosed. She did not want to take the medication, eventually got the right diagnosis. So as with all laws that our legislators provide us, there's a balance. And I happen to believe that these laws about aid in dying balance this tension between recognizing an individual's right and autonomy and protecting vulnerable patients. And I think your 2 points illustrate that perfectly. So looking for your comment.
The case of Jeanette Hall, she had made a settled decision to ask to get the drugs. And she had been persuaded by the promotion of the law, which said that you need this because otherwise you will suffer. It took Kenneth Stevens a number of meetings with her to persuade her. Under the New Style bills, in which doctors are basically forced to comply by prescribing or refer, that would not be possible. And, in terms of misdiagnosis, that can only be seen as a dramatic failure. I mean, and for example, in Massachusetts, we have a Second Thoughts member who got ALS in the 1950s, would definitely have used assisted suicide if it were available. He was a very athletic young man and couldn't cope with being so disabled, but he was so glad it was not legally available because he's still alive today, because you can't predict. And so we know that probably hundreds of people out in Oregon and Washington and now California have died who would now be alive and spending valuable moments with their family and loved ones. And we think that's something that the state has an interest in preserving.
Thank you very much. We'll now have a short break. We're actually due back here at 3:30, 9 minutes.